I've always had a goal of trying to find successful therapies, or as I put it, creating prostate cancer cures and remissions. I had some guy report me like to a state board or something. What do you mean he's creating cures and remissions? I had to talk to an attorney. I said, well, what do you think I'm doing at work? I'm trying to find ways to men to do better. Oh, okay. You can keep the name. Testosterone. Tonight, we're going to discover all kinds of secrets. We're going to learn mysteries, myths, old wives' tales. Reminds me of my grandmother. Misconceptions, illogical conclusions that are true, logical conclusions that are false. Boy, oh boy, I'm excited. Okay, and always remember that, this is my favorite slide of all time, everyone is entitled to their own wrong opinion. I came up with that a long time ago, and I put that especially me with their own wrong opinion. There was a symposium that was held in Boston, Massachusetts. This was in 2003. The 6th annual prostate cancer symposium. And there's a keynote speaker. Somehow they substituted my name and I was a keynote speaker. The other keynote speaker, maybe some of you have heard of Dr. Philip Kantoff, who's the head of prostate oncology at one of the Harvard branches. And this is where I first came up with the challenging prostate cancer treatment biases as nothing sacred. I've lectured, so this is back in 2003 when I lectured on high-dose testosterone. I've lectured on it in London and Vancouver, Canada, at Fred Hutchinson Cancer Center. And I love it when a medical oncologist comes up to me after the lecture, or no, when it's question and answer, raises her hand. Was I aware that testosterone can sometimes worsen prostate cancer? So, no, I haven't heard that. Sir, I beg to inform you that at a meeting of the president and fellows of Harvard College held, this was 1973, you were appointed research fellow in medicine to serve for 1 year from the your obedient servant. I thought that was great. This guy was offering to be my obedient servant. I don't know if any of you are into colonial times and stuff, but you know, you look at Hancock or Adams or Franklin's letters, they're all signed your obedient servant or your most obedient servant. I don't know why they let that saying go. So they appointed me for 1 year, and then, in spite of all the trouble I caused, they did it again the next year. Now, there was a patient that in 1991 had a PSA of 34. Later, his wife told me it was 44. It was a Gleason 6. The slides were lost, no review. They only did sextant biopsies in those days, which is just 6. And in 2005, International Conference of Pathologists changed the Gleason scores. So you can't consider any of this accurate. He was the first patient that I treated with hormone blockade, who refused local therapy. Now, in 1991, the only 2 medicines were Lupron and flutamide. But about 14 months later, or 10 months later, Proscar came on the market. Max became my first triple hormone blockade patient. I treated him for 2 years. I didn't know how long they needed to be on therapy. At the end of the 2 years, put him on 1 Proscar a day, finasteride maintenance therapy. And here are some PSAs in 2002 to 2005. I didn't want to keep on filling them in. I continued to follow Max by phone. He didn't want to drive all the way from San Fernando Valley to my office in the Westwood area. Anyway, he never required local therapy, and he never received a second cycle of hormone blockade. Now, Max, the pioneer for triple hormone blockade, died about 2 years ago. He was 4 months and 99 years old. One cycle, PSA 34. His wife, Eunice, and I spoke earlier this week. I had seen her, she consulted with me on some form of breast cancer, ductal carcinoma in situ, which is non-invasive. And the best cancer surgeon in the valley said, if you had regular invasive breast cancer, we could do a lumpectomy radiation. But non-invasive breast cancer, no way. You have to have your breast removed. So I called him. I said, when you have invasive breast cancer, you could do a lumpectomy. If you have non-invasive breast cancer, you treat it, and it recurs, the worst it could do is recur as invasive breast cancer, in which case you can do a lumpectomy. So why do you tell her you can't do a lumpectomy? So he wouldn't treat her. I had to refer her to another surgeon who happened to be Max's golfing partner. So everyone was happy. Maybe 7 years later, I saw Max for follow-up prostate cancer. Eunice was there. She asked me if I remember when I saw her for breast cancer. I said yes. She said, did I remember calling the, quote, best breast cancer surgeon in the valley? And did I remember what I said to him? I didn't remember. She laughed and said that I called him a barbarian because he wanted to cut off my breast. I told her I did not remember that, but it sure sounded like me. When we spoke this week, she told me she's doing great. She's 96. She's still driving. Okay, so what do we know for sure about testosterone? This is a very old article from July 2016. Now, there's this international conference that was held October 2015. 9 resolutions were passed with unanimous approval. It makes me a little suspicious. This is something that kind of shocked me. High-level evidence shows testosterone therapy increases sexual desire, libido, and erectile and orgasmic function. It shocked me. I never heard of that. Now, they asked Milton Berle, is sex dirty? He said, only if it's done right. I didn't know what that meant. So here are all of these other things that testosterone does, and probably the most important is this one. There were 2 recent articles that said testosterone increases the risk of cardiovascular problems. 2 articles published in 2013, increased mortality, increased risk of heart attack, increased risk of stroke. How dare them? 2014, somebody in power said, you're going to have to write an official retraction. So what did they find? Misreporting results that actually showed a 50% lower absolute risk of adverse cardiovascular events in men who were on testosterone. Somebody didn't like this person. So the second correction, nearly 10% of its all-male database were women. The testosterone in women, I don't think you can do that. So this also mentions the low testosterone with all of the problems it causes. And the nice thing is, when testosterone was administered, there was a 50% reduction in mortality. More than 100 studies showed decreased cardiovascular mortality or risk or problems with testosterone. Now, when a man is diagnosed with prostate cancer, does the level of his testosterone affect his prognosis? What do we say? Yes, no, maybe. Do you want it to be high, low, in between? Okay, so does the level of testosterone affect your risk of developing prostate cancer? How about in women? Okay. So there's this great article last year, relationship between total testosterone levels and prostate cancer. If you use testosterone therapy in patients already diagnosed with prostate cancer, if it's already diagnosed with prostate cancer, after curative intent treatment for prostate cancer like a radical or radiation therapy, no association with increased risk of recurrence or cancer-specific mortality, overall mortality, or need for hormone blockade. Thus, according to the preponderance of reports, there appears to be little risk attached to testosterone replacement therapy in men with a history of prostate cancer. Does that blow you away a little bit? Yes. Now, low testosterone. Consensus is that patients with low testosterone are at an increased risk for higher incidence of prostate cancer, higher grade, extraprostatic extension, biochemical recurrence, positive surgical margins. But when you get to high testosterones, it's crazy. There's articles that say it's worse to have high, it's better to have high, it doesn't matter if it's high. And that surprised me because in the past we were taught high testosterone is protective. Apparently not. Now, there was an article that appeared in the British Journal of Urology International, and it was published 2009. Testosterone replacement in prostate cancer survivors with hypogonadal symptoms. I don't know if any of you saw this article. The author, one of my favorite authors, Leibowitz, R.L. I did have help. All of the 96 patients were patients of mine in compassionate oncology, but Dr. Tanya Dorff, who I know has lectured here, a wonderful lady, is the one who wrote virtually all of the article. There were 96 patients, average age 61, PSA ranged from 0.8 to 6,272. That's kind of high. 20% of the patients, PSA is over 20, Gleason scores 24%, 8, 9, and 10s, and another 23%, 4 plus 3. So 24, 23, 47, 47% of men had Gleason scores beginning with a 4 or worse. That's a ton. These patients were treated from 2000 to 2007. So am I someone, a Johnny-come-lately, who decided to try high-dose testosterone in the last week or two? Nada. The primary therapy when they first presented, radical prostatectomy, 25%, external beam, 13 and 1 for brachy. Hormone blockade alone, 61%, most of the men. Now, why would they have been treated with hormone blockade alone? Maybe they presented with metastatic disease. The mean testosterone on testosterone, 1,391. What is normal? About 300 to 900. The duration of testosterone replacement therapy, 15 months. And notice the longest duration of TRT, 83 months. These guys all had prostate cancer. Most of them, very bad prostate cancer. So 31 of them continued testosterone replacement therapy after the end of the study. Only 7 had radiographic progression, scans, x-rays. PSA after testosterone was stopped alone, meaning the only treatment they had for rising PSA, let's stop testosterone. There was greater than a 30% decline in PSA just from stopping testosterone in about 60% of men. 5% were stable. Another 25% were treated with hormone blockade and/or chemotherapy, following which they were started on a second cycle of testosterone. These guys were on it for 15 months. They got another cycle of hormone blockade, or more likely hormone blockade and chemotherapy. They went right back on high-dose testosterone. And none of the men, by the way, had symptoms of progressive prostate cancer, even though the PSAs went up. So in other words, these weren't men that were dying from it or bedridden or on pain medicines. None of them had symptoms, even though many had high grade, high risk, and even metastatic disease at presentation. In most cases, stopping testosterone, they continued on TRT second cycle. That's 28% of the men. Of the 33 men who had PSA progression while on the first cycle of testosterone, 76% of them were able to get a second cycle. Nice. I explain to patients, if they're on high-dose testosterone, that when you stop testosterone, PSAs fall rapidly and dramatically. And we're going to see that on some patient case reports, because we use supraphysiologic doses of testosterone, which almost never raise PSAs in a dose-dependent fashion. Mary and I have managed our high-dose testosterone patients together. And what is the highest testosterone you remember of? 16,000? We've had men between 20 and 40,000. And when we get them that high, you know what we do with their dose of testosterone? We leave it alone. PSAs don't tend to go up. Abe Morgenthaler developed a what he calls the testosterone saturation theory, and explains why that happens that way. So we've seen testosterone levels 20 to 40,000, never found PSA levels to be correlated to the testosterone. Back in 1993, a total hero of mine, Nick Bruszewski, published a seminal article on intermittent hormone blockade, but their study hinted at prostate cancer killing properties of androgens. Prostate cancer killing properties of androgens. Whereas we all know since 1941, Huggins and Hodges, if you have metastatic prostate cancer, you remove the testicles, symptoms improve for an average of 8 to 14 months, but then in spite of low testosterone, their disease recurs. Now, what these guys showed is if androgens were replaced before progression to castrate-resistant begins, the surviving stem cells should or would give rise to androgen-dependent tumor, which would be amenable to retreatment by androgen withdrawal. And he made this incredibly insightful picture. It's magnificent. And to think that they showed this in 1993, I only started to do it on a large number of patients, a high number of patients, around 2000. But gosh, that's 16 years ago. So there is a Dr. Michael Schweitzer who was at Johns Hopkins, published a paper in 2015, 16 patients, castrate-resistant prostate cancer, low to moderate metastatic burden. They were given testosterone injections, 400 milligrams every 4 weeks. What happens when you get an injection of testosterone? 400 milligrams, first couple days, real high level. what are their testosterones like 26 days later, just before their next dose? Castrate. I don't like castrate testosterones. These men were treated with Lupron and VP16, which is an oral chemotherapy. They gave it for 14 days. 2 out of 16 men were taken off for toxicity. 7 had some response PSA-wise. 7 had rising PSAs. All 7 responders ultimately progressed, average of about 7 months. 2 patients had pulmonary embolism. 1 patient died. I don't think these results are phenomenal, but he calls his program bipolar androgen blockade. He used supraphysiologic levels, doses of testosterone, alternating with hormone blockade. And this year, at the GU conference in January, he presented a paper, Hormone-Sensitive Metastatic Prostate Cancer, Low Metastatic Burden, Supraphysiologic T levels, castrate before next shot. They initially got 6 months of hormone blockade. Then 12 weeks of testosterone shots, followed by 12 weeks of hormone blockade. 33 patients, 1 withdrew, 3, their PSA responses weren't good enough. There were 29 patients left. 3 of them progressed while on the initial 6 months. 17 out of 33, PSA less than 4. 3 out of 33, PSA less than 0.2. Now, Paul Lang is professor and chairman emeritus, Department of Urology, University of Washington, director, Institute of Prostate Cancer Research, Fred Hutchinson Cancer Center. He had a patient, PSA 174, low testosterone, a Gleason 9, lymph node positive disease. The man was lost to follow-up for the next 10 years. When he saw him 10 years later, he was NED. You guys know what that means? No evidence of disease. What? With this? No way. No evidence of disease. PSA, less than 1. Serum testosterone, over 2,000. He found out the patient had been under the care of a medical oncologist who'd been using intermittent high-dose testosterone. How about a case report? We have a 57-year-old African-American, Gleason 7, 6 positive cores, radical prostatectomy, Memorial Sloan Kettering, February '03. Pathology, Gleason 4+4, total 8, perineural invasion, vascular invasion, extracapsular extension, right seminal vesicle involved, 2 out of 13 lymph nodes involved. Not very good. He was told he was incurable. PSA began to rise within a few months of surgery. I saw him in August '04. PSA was 2, testosterone 334. He was started on our 3-pronged therapy. 1 month into therapy, PSA 0.017. Then became unmeasurable, and he completed 3-pronged in August 30 of '05 and was started on high-dose TRT. So if we look at September '05, PSA 0.3, testosterone 4,064. Superman. January '06, 0.03, 2,400. April '06, 0.03, 3,000. February '07, less than 0.01, testosterone over 4,000. April '08, 0.07, 3,100. Here was a 5,000. Oh, this was May 14 of '08. February '09, 0.13, 7,377. Wow. February of 10, 0.13, 4,800. March of 11, 0.22, 3,400. At that time, he'd been on testosterone for 5.5 years. PSA was rising 0.04 per year. January of 12, 0.52, 2,100. 0.67, 3,400. In January of 13, he had gone up to 2.52. His testosterone doses were being cut. Notice 3,400, 2,800, 500. PSAs were going up, just the opposite of what you would believe. So this time, he'd been on TRT 7.5 years, and I told him that when PSAs begin to rise on high-dose T, reducing the level of testosterone virtually always causes PSAs to rise. In January 13, he stopped his testosterone, and 2 weeks later, PSA was 0.36, testosterone 129, July 0.04, testosterone 98. Now, this is something very important. I've stressed every month that a man is on hormone blockade brings him 1 month closer to having castrate-resistant prostate cancer. And which to me is the first time in a disease course that the disease is life-threatening. Prior to castrate-resistant prostate cancer, I believe it's possible for a prostate cancer patient to have a normal lifespan. The goal of therapy is to avoid castrate-resistant disease. That's my opinion. Every month that a man survives with a normal or even better supraphysiologic testosterone level is an extra month of survival. You're not giving up 1 month. You're not getting 1 month closer to castrate-resistant disease. That's why I think someone had asked a question about his PSA was 0, he'd been on hormone blockade, what should he do? I don't know any of the details, but high-dose T is something to think about, depending on the real facts. Okay, so the question, why was he not responding? Because he was on the same medicines that did not work when he stopped testosterone 10 months earlier. But in January of 14, his PSA was 0.9, testosterone 1,000, 1.8 in February, 1,000, March 2.1, 1,600, 1.6, 3,100, 0.96, 3,300, 1.2, 4,100, 1.16, 3,500. Now, what happened? What happened is he agreed to be treated with a medicine called ethinyl estradiol, form of estrogen. And our patients that are on high-dose testosterone, where's their testosterone coming from? Is it coming from their testicles or adrenal glands? No, they're rubbing it on their skin. So if you treat them with 1 milligram of ethinyl estradiol, what happens to the testosterone levels? Nothing. The reason is their testosterone is coming through the skin. Their body's not making any testosterone. Now, estrogen is thought to lower PSAs by turning off gonadotrophins, pituitary hypothalamic, and maybe have a direct cytotoxic effect on prostate cancer cells, meaning that it can kill prostate cancer cells. So in our patients, when we give them that 1 milligram of ethinyl estradiol, the testosterone levels do not drop. What happens to their PSAs? Their PSAs almost always go down. How long does that take? Mary, on average, 1 or 2 weeks. PSAs to drop. Do we have very many men in whom the EE did not work? No. we've treated at least 40 or 50 men, some of them multiple cycles. Now, throw in something unusual. This guy had a pulmonary nodule that was a certain size. It shrunk and then grew, and Dr. E did some studies. He went to surgery, small nodule, metastatic prostate cancer. It was removed. He got another cycle, 3-pronged, and just the other day, July 19th of 16, PSA less than 0.1, testosterone 1200. Isn't that nice? This is a Dr. Juno 9, PSA 5.18, Gleason 8, self-medicated. He had 4 out of 12 cores positive. He had color Doppler ultrasound, large volume infiltrating tumor. His PSA had risen to 52, seminal vesicle involvement. We saw him March of 14, PSA 52, his PAP was elevated and started 3-pronged. His PSA came right down. April of 15, start high-dose testosterone. 2 weeks later, less than 0.015, testosterone 1,000. In May, 0.052, 0.2 in July, testosterone 1,200. Now, he has his prostate gland. What happens when your testosterone recovers on its own, or you take testosterone and you have a prostate gland? Testosterone is going to stimulate your normal prostate gland cells to make PSA. So you have to have PSA. In November, 1.78, testosterone over 1,500. Then PSA was 10. He was taking a bunch of over-the-counter products. Most recently, PSA 5, testosterone 2,200. One of my favorite patients, 81 years old, 30-pound weight loss, intractable bone pain on morphine, rock-hard prostate, bone scan over 100 METs. PSA 6,272. He was told he had 3 months to live, got a shot of Lupron. He lived in Louisiana, came to see us, and his PSA dropped to 0.3, testosterone 134, started high-dose testosterone, but in July 02, and it had to be stopped just 4 months later. His testosterone was good, the PSA was 7, but it rose. In April 03, 6 and 165, testosterone number 2. His PSA 1 month later was 16, testosterone 1900, and testosterone was fine on 3rd cycle, but April 04, by August 04, 51, testosterone 1400. We had to stop his testosterone. Later, he died of cardiac problem with a PSA of 10. For his 85th birthday, his family took him to his first ever trip to Hooters. Anyway, we would love and appreciate thanking our staff, Mary Duong, our PA, Lydia and Emily, RNs, Joanne, practice manager, Maria, front office manager, Mon Cherie, front desk secretary, Kylie, medical assistant, Dr. E and myself. We thank all of you for helping us to take care of our patients. And as always, my closing slide, be happy, be well, live long and prosper. Thank you very much.